I'd like to very much thank Dr. Ved Prakash and the other organisers for inviting me to speak to you all today. It's indeed a great honour to be part of this first international online symposium. And I think it's great that it's held on the day celebrating the date of one of the great contributions of Dr. Mukherjee to IVF in India. So 7 years ago, at the request of BioNews, I wrote an opinion piece based upon 15 years of combined data from Westmead Fertility Centre in Sydney and Assisted Conception Australia in Brisbane, titled An Inconvenient Truth: ICSI is not necessary for the majority of IVF patients. Our data showed quite clearly that conventional insemination, not intracytoplasmic sperm injection, or ICSI, was optimal treatment for up to 60% of our patients. However, since ICSI is used predominantly these days, evidence that suggests ICSI to be unnecessary represents an inconvenient truth. In my presentation, I shall review the literature published since my opinion piece to help determine where the truth now lies. Following a brief introduction to ICSI, I shall discuss its indications. I will then review the use of ICSI in unexplained infertility, advanced maternal age and diminished ovarian reserve, non-male factor infertility, pre-implantation genetic testing, and in vitro maturation before providing a brief summary. In this introduction, I will briefly discuss the ICSI technique. The ICSI procedure entails the deposition of a single spermatozoon directly into the cytoplasm of the oocyte, thus bypassing the zona pellucida and oolemma. Therefore, the oocyte can be fertilized independent of the morphology, motility, and DNA integrity of a single sperm. Now I shall discuss the indications, safety, advantages, and disadvantages of ICSI. ICSI was originally developed for the alleviation of severe male factor infertility, but has since been increasingly used for non-male factor etiologies, including oocyte donation, idiopathic infertility, poor quality oocytes, low oocyte yield, and advanced maternal age, previous fertilization failure, PGT, IVM, cryopreserved oocytes, and even for all patients in some centers, resulting now in over 70% of ICSI usage. Some practitioners advocate ICSI for all patients, but concerns remain regarding its long-term safety. Although data regarding the health of ICSI children is reassuring, we still don't know whether this holds true for non-male factor infertility and increased risks of preterm birth, small babies for their gestational age, congenital malformations, chromosome aberrations, advanced cardiometabolic outcomes, and transgenerational inheritance of infertility have all been reported. ICSI offspring are under 30 years of age, so there's limited information concerning long follow-up data. An analysis of the possible advantages and disadvantages of ICSI in non-male factor infertility was recently reported by the Spanish infertility SWOT group. So they looked at the strengths, the weaknesses, the opportunities, and the threats. And you can see here that the strengths include increased fertilization rates and decreased fertilization failure in patients with unexplained infertility, and minimizing the risk of couples with prior fertilization failure, and possibly increasing embryo quality and increasing pregnancy rates in patients that have possibly disturbances of the sperm zona pellucida binding, and avoiding possible contamination with sperm DNA where pre-implantation genetic testing for monogenic conditions is performed. The weaknesses include lack of standardized guidelines to define severe male factor infertility, as Ashok talked about earlier, and the lack of well-designed randomized studies, premature removal of cumulus cells, the invasiveness of the technique, and complexity of the technique for operators, and therefore dependent upon operator experience and other technical factors. Possible complications such as imprinting, DNA methylation, and alteration of the sex ratio, and no clear benefit to female-related factors or poor prognosis patients, and no effect upon reproductive outcomes, and no evidence of a cost benefit. Possible opportunities include the selection of oocytes and the ability to artificially activate oocytes, and technical improvements such as IMSI, PIXI, and genome editing through CRISPR and Cas9. And the threats to the technique include the indiscriminate application of ICSI and overuse during PGT, an improvement of IVF and possible long-term effects of ICSI on infants, children, and indeed adults. So though the SWOT group recognized one of its major strengths to be the virtual elimination of further complications due to fertilization failure, the overall evidence from their analysis suggested that ICSI is not justified for use in non-male factor infertile couples due to its greater technical difficulty, higher costs, and unnecessarily invasive nature. So ICSI has been proposed for patients with idiopathic or unexplained infertility because it may be able to overcome barriers to fertilization that could be the cause of otherwise unexplained infertility. In a systematic review of well-defined unexplained infertility, this forest plot of a meta-analysis of over 900 couples with 11,767 sibling oocytes randomized to either conventional insemination or ICSI shows that the pooled likelihood of a mature oocyte fertilizing was significantly greater with ICSI. And this forest plot from the same meta-analysis shows that the pooled likelihood of fertilization per allocated oocyte prior to randomization was also significantly greater with ICSI than with IVF. And this forest plot from the same meta-analysis of well-defined unexplained infertility shows that the pooled relative risk of total fertilization failure was significantly greater with IVF than with ICSI. It's been suggested that older women are more likely to produce oocytes with defects of the zona pellucida or ooplasm that could adversely affect their fertilization rate following conventional IVF. In a systematic review of women aged 38 years or over with non-male factor diagnosis, this forest plot of risk ratios from a meta-analysis of 7 studies, including 8,796 oocytes randomized to either conventional insemination or ICSI, showed no significant difference in fertilization rates. And this forest plot from the same meta-analysis showed that there was still no significant difference in fertilization rates between IVF and ICSI, even when there were 3 or fewer oocytes retrieved. And in a retrospective cohort study of 8,597 elevated FSH only and 38,926 diminished ovarian reserve only cycles taken from the Society of Assisted Reproduction Technology Clinic Outcome Reporting System database, there was a significantly only cycles. In the diminished ovarian reserve only cycles, there was no significant difference in fertilization rate, but again, there was a significantly lower clinical pregnancy rate following ICSI, which was also associated with diminished odds of a live birth, the data not being shown in this particular graph. The use of ICSI in non-male factor infertility has been proposed as a means to avoid fertilization failure and thereby potentially increase the number of embryos available for patient treatment. This multi-center randomized clinical trial of clinical outcomes following conventional IVF or ICSI in couples with non-male factor infertility was conducted not long after the initial development of ICSI. The data from 415 couples at 4 IVF centers in the UK showed a significantly higher implantation rate and pregnancy rate per cycle with IVF, with significantly less lab time required compared to ICSI. ICSI was originally recommended for PGD to ensure monospermic fertilization and eliminate the possibility of PCR contamination by spermatozoa attached to the zona pellucida. We now know that sperm DNA fails to amplify following trophectoderm biopsy and next generation sequencing, or NGS. This single center prospective pilot study of 30 couples having NGS following trophectoderm biopsy on days 5, 6, or 7 to determine blastocyst ploidy included 568 sibling oocytes assigned to conventional IVF or ICSI. Though there was a significantly higher oocyte degeneration rate following ICSI and higher polyspermy rate following IVF, there was no significant difference in fertilization rates or embryo development. Furthermore, in this pilot study, there was no significant difference in the total number of blastocysts biopsied, nor the euploidy rates, with the euploidy rate of 49.8% following IVF and 44.1% following ICSI. And this single center retrospective study of PGTA by NGS following conventional IVF or ICSI and trophectoderm biopsy in day 5 or 6 also showed no significant difference in euploidy or aneuploidy rates, though they did observe a non-significant increase in mosaicism following IVF. The use of ICSI has been proposed for IVM because of potential hardening of the zona pellucida during in vitro maturation of oocytes. In this study of 239 IVM cycles without hormonal priming, patients were assigned to conventional IVF or ICSI depending upon their sperm quality. Though the fertilization rate and number of embryos available were higher following ICSI, the clinical pregnancy and implantation rates per immature oocyte retrieval were significantly higher following IVF. And in this pilot study of 8 IVM cycles using minimal priming with FSH, 150 immature sibling oocytes were randomized to conventional IVF or ICSI. There was no significant difference in fertilization rates or the number of usable blastocysts, and the cumulative implantation rates were identical. So what can we conclude from the peer-reviewed evidence published over the past 20 years? ICSI is being used increasingly around the world for non-male factor indications, despite the fact that it demands additional lab experience, resources, effort, and time. In idiopathic infertility, ICSI increases fertilization rates and decreases rates of failed fertilization, though it doesn't improve live birth rates. However, ICSI fails to improve fertilization and live birth rates in advanced maternal age and diminished ovarian reserve, in non-male factor infertility, in PGTA cycles, and in vitro maturation. Clearly, therefore, ICSI should be used primarily for male factor infertility and failed fertilization. So for those that would like to read further on this, here is the selected bibliography. Thank you very much.